Good afternoon, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar entitled Best Practices in Establishing a Controlled Substance Diversion Surveillance Process. We are thrilled to have Dr. Amisha Arya as our guest who will present. Dr. Amisha Arya is the Director of Pharmacy of Medication Regulatory and Compliance for the NYU Langone Health System. In her role, she leads medication-focused standards interpretation, policy and process standardization, and continuous compliance. She chairs the NYU Langone Health Drug Diversion Response Team, an interdisciplinary committee tasked with establishing standardized best practices regarding controlled substance diversion monitoring and response. As an advocate for pharmacy technician certification and registration, Amisha co-founded the ASHP ACPE accredited NYU Langone Health Pharmacy Technician Training Program, the first institutional-based technician training program in New York State. Amisha received her Doctor of Pharmacy from the University of Georgia College of Pharmacy and completed her PGY1 pharmacy practice residency at the Mount Sinai Hospital. She is a board-certified sterile compounding pharmacist and certified Joint Commission professional. She is a recipient of the New York City Society of Health System Pharmacists Joel Yellen Award of Merit. Amisha is an active member of the New York City Society of Health System Pharmacists, New York State Council of Health System Pharmacists, and American Society of Health System Pharmacists. So before we get started, I'd like to share a few quick points. First, for those of you who have any tech issues during the presentation, please use the chat option to communicate with the office, and every effort will be made to assist in a resolution. For those of you who have any questions throughout the presentation that you would like to direct to the speaker, please use the question box or chat option. And finally, the CE code for the program will be provided at the end of the program today. And Dr. Arya, if you'd like to get started.
Yes, thank you so much for that warm welcome. And I'd also like to thank NYSCHP for the opportunity to speak today. I have no conflicts of interest to disclose. So our objectives today are to discuss drug diversion and associated risks to healthcare providers, patients, and health systems. We're going to review considerations as part of developing a complete controlled substance process. We're going to discuss the composition and organization of an interdisciplinary drug diversion compliance steering committee and associated response team. We're going to consider best practice strategies to improve diversion visibility, surveillance, investigation, and response, and we will review a sample investigation and response process. So let's review some definitions and acronyms that we will use today. Controlled substances, or CS as we'll refer to them, got their start with the Controlled Substances Act, which was enacted in 1970. So these are drugs whose manufacture, possession, and use are regulated by the federal government in the form of the DEA or the Drug Enforcement Agency. These drugs are classified into Schedules 1 to 5 based on their medical use and treatment in the United States, their relative abuse potential, and their likelihood of causing dependence when abused. Drugs are regularly added, removed, and transferred from one schedule to another, and you can always find the current DEA schedule by going to their website and looking up Title 21. Drug diversion is the transfer of a legally prescribed controlled substance from one individual for whom it was intended and prescribed for to another person for illicit use. And we have some acronyms we'll use for healthcare workers, healthcare systems, and your Controlled Substance Diversion Prevention Program. So unfortunately, diversion of controlled substances is common, but it's rarely discussed openly. And I know some of us have seen the alarming statistics and have heard of recent high-profile events. It's estimated that 10 to 15% of healthcare workers misuse alcohol or drugs at some point in their careers. 1 in every 10 of healthcare workers, professionals are struggling with addiction or abusing drugs not prescribed for them. 34% of incidents of diverted opioids occur in hospitals, followed by private practice, long-term care facilities, and then retail pharmacies. In many of these cases, healthcare workers are pilfering or using their patients' pain medication. And these stats are alarming because they're basically the same incidence as the general population. But as we all know, healthcare workers have increased access and availability to controlled substances, so the problem runs deep. Among healthcare workers, those that are highest at risk are psychiatrists, anesthesiologists, ED personnel, nurses, pharmacists, and pharmacy techs. Providers and nurses are responsible for opioid diversion around 2/3 of incidents. So what are some commonly diverted drugs? We see, of course, opioid pain relievers such as codeine, fentanyl, hydromorphone, meperidine, morphine, oxycodone, hydrocodone combinations. We see benzodiazepines such as alprazolam, clonazepam, and lorazepam. And we see high-cost antipsychotic and mental health drugs such as aripiprazole, ziprasidone, risperidone, quetiapine, and olanzapine. So what are the costs of drug diversion, and who are these costs billed to? Costs to the healthcare worker include their health, of course, usually involving progression to other substances, eventually loss of employment, loss of licensure. The cost is really life as they know it. The cost to the patient includes suboptimal, possible harmful care if their caregiver is impaired, poor pain management if their caregiver is diverting their intended medications and replacing them with something else, such as saline instead of fentanyl. There's also the risk of infection if a caregiver has used a medication syringe, such as in the case of taking overfill from a vial and then giving the remainder to the patient. And then finally, there are costs to the healthcare system. It's estimated that the total economic burden of prescription opioid misuse alone is a staggering $8.5 billion a year, including the cost of healthcare, productivity loss, addiction treatment, and criminal justice involvement. And this includes patient harm. The CDC estimated over 30,000 individuals were exposed to Hep C in the past 10 years. The patient medical records also may be inaccurate if their caregiver is charting pain meds that were never given or alternate drugs given. There are also, of course, regulatory and legal risks to the organization, including fraudulent billing, liability for resulting damages, and the healthcare system's reputation for safe, quality care on the line. We're going to talk today about a framework to support you in developing a comprehensive diversion prevention program for your organization in order to protect patients, employees, the organization, and our community at large. Ultimately, each organization is responsible for developing a program that complies with federal and state laws and regs, but also one that applies technology and diligent surveillance to routinely review processes' effectiveness and seek to proactively prevent diversion. So now I'm going to touch on our compliance journey as an institution. A little bit about NYU Langone Health. We are one of the nation's premier academic healthcare systems. Our trifold mission is to serve, teach, and discover, and this is achieved through an integrated academic culture devoted to excellence in patient care, education, and research. NYU Langone consists of 6 inpatient locations, our Hassenfeld Children's Hospital, our Rusk Rehabilitation, and our network of Perlmutter Cancer Center ambulatory infusion centers. Our specialists treat a full range of medical conditions in both inpatient and outpatient settings at locations throughout New York City's 5 boroughs, Long Island, New Jersey, Westchester, Putnam and Dutchess counties, and Florida. So a little background, around 9 years ago, we embarked on a journey to improve our compliance with controlled substances. At that point, we really didn't have a standard approach to drug diversion, both from a mitigation as well as a reaction perspective. We set out to create a mission, vision, and perspective for our organization. We wanted to look at compliance from a multidisciplinary global approach rather than looking at individual siloed sites. Our state at that point, around 9 years ago, we had differing policies between campuses and disciplines, and pharmacy was frankly considered the narcotic police for all disciplines. For diversion surveillance specifically, the process was a QA audit with solely just our ADC data feed, which includes removal, waste, and returns, and then manually reconciling this with our EMR administration data. It was honestly like looking for a needle in a haystack, and we knew we could do more. So at that point, our goals were to standardize our policies and procedures among our sites. We wanted to shift our culture to one from pharmacy doing the policing to more of the unit managers' oversight of their staff. We wanted to be more accurate. We wanted to hone in quickly on open variances and increase our speed in detecting anomalous behavior. We wanted to move quicker, and we didn't want to manually comb through the records anymore. We wanted to streamline our audits. So we started by asking ourselves, what would the ideal state look like? Where are our current vulnerabilities with our process, and where would a diverter look to break into our system? We took these questions and boil it down to looking at 19 different reports of what data we would look at and the combination of these activities. For instance, purchasing and ordering. This is what we were trying to automate. After we looked at what it would take with the resources we had in place, we realized it wouldn't be impossible to do this, and it would be not really value add to comb through these 19 reports. So what steps could we take? And one of the best things we did was look outside healthcare and look to analytics and AI. We could be doing more and seeing more, and so that's what we decided to do. We wanted to work smarter and not harder. So I'll be touching more on automation and AI later on and exactly what we did. We achieved some of our goals by applying some established best practices, and we'll be diving into these today. So we'll look at the association between regulation, policy, and process. We'll look at our committee structure, including organizational leadership buy-in and culture. We'll look at education, our auditing surveillance process, and our investigation process. So first, we dove into our processes, policies, and the regs to make sure that all of these lined up, as all three gears are needing to constantly align and sync up for compliance. So this is a busy slide, but what we have here shows that the procurement, prescribing, administration, transfer of controlled substances are highly regulated by the federal state laws, such as the DEA, and in our case here in New York, the B&E and our New York State Board of Pharmacy. We should also be compliant with standards put out, published by the Joint Commission and CMS, as you see there. And also a good thing to add is to consider best practice documents. And there's a few great ones put out by ASHP, ISMP, and the Minnesota Hospital Organization has a great one with a corresponding toolkit that's very helpful. So altogether, these requirements serve as a foundation of your organization's policies and procedures. So next, we looked at all steps within our controlled substance process, from access and procurement through destruction and reverse distribution, and along to waste testing and monitoring. So these might look slightly different based on your institution's distribution model. We wanted to make sure that every piece of the process was defined so that we could more easily standardize among our sites and also identify any loopholes and vulnerabilities. So as you can see here, we start with access, we go through procurement, receiving, stocking and storage, ordering, verification, dispensing, administration, and then wasting or returned if unused. We include some overall processes such as cycle counting, reverse distribution, discrepancy resolution, and then our diversion surveillance processes such as auditing, waste testing, and investigation. With the policy piece, we took all the steps that we just reviewed and ensured that we were compliant with the regs and application of established best practices. And we put all this in the policy. So let's talk about scope. We should include all settings in which controlled substances are stored and utilized, including but not limited to inpatient areas, outpatient areas, community settings, and any applicable physician practices. So some things to keep in mind. You want to consolidate your policies if you have a few overlapping ones, and keep your manuals streamlined to ensure that you don't have any conflicting or old documents floating around. You also want to make sure that your policies are as interdisciplinary as you can make them. If there's a separate nursing, pharmacy, and anesthesia policy on wasting, why? Should there be? Can you close any gaps and kind of consolidate those into one interdisciplinary stance? Along the same vein, you'll want to standardize these documents across your sites as much as possible to ensure the same quality and compliance across your system. And then, of course, once you're done with all of this, the job is never over. You'll want to keep reviewing these in your committee setting, which we'll get to, at least every 3 years, but ideally annually. You'll want to keep a lookout for new services and sites and introduce your program as they onboard. In addition to including all steps of the controlled substance process, you'll also want to identify risk points or vulnerabilities and develop corresponding risk reduction strategies. So as we've reviewed, your policy should reflect current legal and regulatory requirements. And what you can include here is records retention, biennial inventory, DEA registration, power of attorney designations, procurement requirements and forms, prescription authentication, surveillance, investigation, reporting loss, including what does your institution consider a reportable loss, which is sometimes defined. Authorization to access, waste, and transfer. So just to touch on how comprehensive you can make your policies, I'm displaying here kind of our index for our controlled substance manual at NYU. So we actually decided to compile everything into one large document for ease of locating this for all of our disciplines. And of course, this is something that we regularly review and update. You could also choose to break this up into different documents based on part of the process. Maybe you want a different document for procurement and that sort of thing. But you will want to keep your documents as interdisciplinary and system-wide as possible to help evaluate and close any process gaps that are identified. You also want to assure that these procedures are applied universally. So there are many points where diversion may occur and many methods of diversion. Your controlled substance prevention program should build in tight controls through processes, checks, and balances. Diligent surveillance and prompt interventions are required to prevent, promptly identify, and investigate diversion. So going back to our process risk points and vulnerabilities, let's look back on our process and identify some common risk points and potential methods of diversion. And you'll definitely want to evaluate these for your institution and include some mitigation strategies in your policy and process. So during the procurement risk point, some potential methods of diversion could include purchase orders and packing slips being removed from records, unauthorized individuals ordering on stolen DEA 222s, and product containers being compromised. During the preparation risk point, some potential methods of diversion include controlled substances being replaced with alternative similar-looking medications when pre-packed, removing volume from a pre-mixed infusion, multi-dose vial overfill being diverted, and preparing syringe contents being replaced with saline. During the prescribing risk point, some potential methods of diversion include prescription pads being diverted and forged, prescribers self-prescribing, verbal orders placed in your EMR but not verified or co-signed, and written prescriptions altered by patients. During the administration risk point, some potential methods are controlled substances are removed from an ADC on a discharge or transferred patient, so a patient no longer on your unit. The meds documented as given but not actually administered. Waste is not adequately witnessed and subsequently diverted. And a substitute drug is removed and administered while the controlled substance itself is diverted. During the waste and removal risk point, some potential methods are controlled substance waste being removed from an unsecure waste container. Controlled substance waste in a syringe is replaced with saline, and expired controlled substances are diverted from their holding area. So next, let's talk about organizational buy-in and committee structure. It's really important that your healthcare organization approach diversion prevention with the same gravity and diligence that you would apply to a compromise to patient safety, and also promote that same kind of culture awareness to diversion prevention. Organizations should support the program by providing adequate resources, including human resources, facility controls, and technology. I know it's very easy to say, but it's a great goal to include your C-suite executive or your VP in your early discussions about building out your program if you already don't have one. At NYU, we have an interdisciplinary system-wide controlled substance compliance steering committee. This team meets quarterly and we discuss ongoing projects, opportunities, policy and process review, data tracking, and future plans for controlled substance surveillance and response. The group helps us strategize around our philosophy and culture, what are our tactics, what are our strategies, and steps to take when there's a concern. Within this group, we also have a few members that are part of our drug diversion response team. And this team meets more on an ad hoc basis when there's an active investigation starting. And the group is kind of tailored to the type of investigation and which discipline it involves. So for instance, if there's a potential diversion in the OR, we would of course include our anesthesia representative, but we may not need to include our nursing rep. I'll go into more of the investigation process later on. And also one last point is the response team reports out on investigations and follow-up items at the steering committee. So it's kind of everyone's in the know of what's going on. For our steering committee and response team to establish a framework, we brought together groups that are truly interdisciplinary with representation from each campus. And I can't really emphasize enough how important this is to have this team in place and operating. Each of the members are key stakeholders and their participation and buy-in was necessary and so important for the success of our plan and our group. One of the most important aspects of diversion prevention is implementing these safety teams within your organizational structure. So our steering committee has, and yours should have, 1 or 2 leads to ensure some streamlined communication and redundancy. The team scope should include prevention, detection, and investigation. And you can choose champions from the following disciplines, which we have up here. Your medical staff, and you want to make sure to include your graduate medical education office for residents, pharmacy, anesthesia, nursing, human resources, security, employee health, patient safety, risk management, compliance, administration, and legal and communications are sort of ad hoc for us. So as you can see, it's definitely the more the merrier. So a champion should be included from each discipline for each campus and areas in which, of course, controlled substances are utilized. The team leaders can consider a few things like an email group to kind of keep everybody included on communications, and also a secure share drive to house your relevant documents, policies, your team charter, your meeting agendas and minutes, and all your investigation documentation. So you'll want to meet on a regular basis, and of course ad hoc when there is relevant investigations. Something important to have in writing is your team charter, and you'll kind of want to refer back to that and make sure that it's updated and includes really your goals and just aligning your culture with where you want it to be. Like we discussed, you'll review and update your policies and procedures, discuss your system-wide implementations and how those are going. And you'll also want to discuss current or recent investigations and kind of do a debrief. You want to ensure that your process was followed. If it wasn't followed, should anything be changed with it or updated? And you'll want to officially close out investigations. This group should also promote your organizational-wide culture of substance abuse awareness, which is super important. And we have some leaders here that have buy-in and also could help spread that awareness and that culture. So next, let's touch on employee education, which is one of the most effective and critical pieces of your program. Providing employees with this knowledge and with resources to identify and report instances of suspected diversion may identify these cases. The essential pieces of staff education around controlled substance diversion are, of course, the definition and prevalence of diversion, consequences of diversion, which we went over earlier, patient harm, your institutional reputation, staff member harm, of course. You'll want to include signs and symptoms of substance abuse, impaired state, and identifying diversion among your peers. You'll want to include some policies and procedures, of course, related to your processes such as handling and wasting, and also your investigation and reporting policies. You'll also want to add resources available to your employees who suffer from substance abuse disorder, Maybe your institution has a sort of compliance hotline you'll want to include in that. So the detail you want to include will depend on your employee's role and access to controlled substances, and you'll want to tailor that education accordingly. So ideally, all staff members should have a baseline level of education around diversion prevention. Those who handle controlled substances directly should receive kind of a more detailed layer of education. There should also be education provided to supervisors on how to handle suspected diversion or concerns. Another last thing you may want to consider is a user acknowledgement statement before they have their access given to them for controlled substances. So this is really just to convey their understanding of the training and that they understand the gravity of this access and responsibility. And also this acknowledgement can be useful if you need to kind of pull that up for legal use during times of investigation. So how do we deliver this training? There's several options, and I know we deliver a lot of training in what we do in pharmacy, so you probably already do a lot of these things with other topics. So we have our computer-based training. It could range from 10 minutes to something more like an hour-long module. We have new employee orientation. You can include something in that. Some level of education that you could include within the first 90 days after an employee's hire. You could do CEs. Sometimes offering CE credits will encourage staff members to attend. Grand rounds is a great way to address a captive audience and can be scheduled on a regular basis. You could do in-services. Handouts would be a good companion to some of these other types of education. And of course, some one-on-one training is always great. So as we talked about, the type of delivery for this education will really depend on the employee's access and their supervisory role and if they're involved in investigations or not. You could also consider including these types of education points in if you have an overall kind of medication quality safety module that includes things like look-alike, sound-alike, smart pumps, different things like that. You can add this to that already existent module if you have something. For us at NYU, staff training was definitely not a one-time event. We have kind of a bigger one-time event upon hire, and then we do automated push-outs every year on our electronic platform. So automated technology, including your automated dispensing cabinets, pre-packing devices, and diversion monitoring software have been developed to assist with management of controlled substances, including inventory control, documentation of removal, administration, waste, billing, and auditing. The level of automation may depend on the risk assessed by your organization for various areas. For example, your high-risk areas generally include your main pharmacy controlled substance vault, anesthesia and procedure areas, your ED, surgery centers, and also remote locations that might be located farther away from the main hospital. To the greatest extent feasible, auditing processes for your controlled substances should be implemented. The more automated your processes, the less it becomes like looking for a needle in a haystack, and it'll help you work smarter, not harder. Automation benefits include increased accountability for controlled substances and increased diversion detection. Some common barriers to adoption include lack of interoperability between your systems, lack of ongoing financial or human resources necessary to utilize these available technologies. So let's take a step back to talk about barriers. We need to consider something about using AI or analytics to really help us, which we'll talk about in a bit. It's really only as good as the information that you put in. So it's important to keep in mind to use and implement use of automated technologies as much as we possibly can. If there are pieces of your controlled substance process that are manual, such as like your waste documentation in your OR areas, this piece will not really be picked up by your auditing feed, and it will kind of create even more work sometimes to reconcile all of that. So you want to kind of work everything into your automated process as much as you can. Technologies to support controlled substance accountability, including the use of artificial intelligence for diversion monitoring, continue to evolve. The use of these technologies can help pharmacy staff focus on investigation of discrepancies and other higher level tasks. However, automated technologies still require considerable ongoing diligence to maintain. So you want to really make sure that you have kind of your IT pharmacy department on board. You'll kind of need to bounce ideas off them, make sure that the feeds are running well. It really is a huge collaborative process. So next, let's touch on some of the reports that you can utilize if you're looking towards the manual report route. So this is if you have more of the reporting software that includes your ADC reporting. So that includes removals, waste witnessing, and returns. So for the full picture of each transaction, you might need to manually combine these with your EMR data to have that administration piece. But this is a good start to your auditing processes if you're new. Some of our basic reports are controlled substance usage trends, waste trends, null transactions, so that means any transaction that appears to be canceled without any drug removed, appears being the key word here. Discrepancies or variances within the cabinet or the transaction. Dispense after discharge or transfer, so just what it looks like removing a medication for a patient that's no longer on the unit. We have patterns of removal, waste witness buddies, so this is when a clinician wastes only with a certain other clinician when there are others around on the floor. So this might be a tip-off to something to look into further, that network. So once you've incorporated these, there's some next level reporting you can include. So discrepancy resolution auditing, timely and appropriate wasting. So in most cases, it's within an hour after removal of the controlled substance from your ADC cabinet, but this should definitely be defined in your policy so that everybody's aware of that. Random waste testing, this is when you can randomly test waste samples that you can procure from vulnerable areas such as your OR. ADC access and activity, this should also be defined in policy and should include some access controls. How does one gain access to your ADC system? How does their access change if their role changes? How is it removed when they're terminated? And how often is all of this reviewed? You can also include your ADC override audits. So this involves ADC overrides and when a med is removed from a cabinet during an emergency without an order and should actually be appropriately reconciled after the emergency event is over. So some institutions like us, we look at this as a whole, not just for controlled substances, but it is important to note that for controls, it is kind of a loophole in which a narcotic can be removed and an order really never placed. So we have barcode med administration. Once again, we might be looking at an overall report of non-narcs and narcs, but looking at this as well, and reconciliation audits. So I want to go into a little bit more on waste testing. Auditing wasted drugs using assay technologies is a great best practice to incorporate. So devices exist which can be used to confirm the contents of wasted medications returned to pharmacy. So these devices use either refractometry or ultraviolet spectroscopy. And testing all returned products is kind of unrealistic. There's a lot of labor involved with this, a lot of moving around controlled substance waste, which is a vulnerability in and of itself. So to keep, burdens low on this, you kind of want to target your high-risk areas, maybe an area in which there's still some manual processes going on. In your ORs, if your anesthesiologists are maybe there's not a waste witness going on, that'll definitely want to be an area that you at least try to do some kind of waste testing there. Lastly, let's talk more about some auditing using data analytics. So from the ADC reporting, technology is now advanced and there are data analytics programs that pull together your EMR along with all of these ADC feeds. So it gives you kind of a full picture of what's going on with every transaction. And some programs are even pulling in time clock records, and I'll talk more about that shortly. So these data software programs will flag high-risk diversion transactions. Um, the person accessing these alerts daily can see why the data program flagged the transaction, and it's more of like a 100% audit, and really just brings to light the transactions where everything did not add up to zero, rather than having to manually go through an audit that's not 100%. So implementing data analytics requires partnership between pharmacy, your informatics department, like we said, nursing, anesthesia, to successfully go through an implementation like that. It will show you individuals' behavior as well as trends and behaviors of employees in a general area, as it's important to account for differences in types of areas. So a lot of times these programs will have different modules for an anesthesia area, a nursing area, and pharmacy. Sharing information on trends for a department will help with addressing the root of the problem and detecting and identifying other concerns. So for example, if an area has a high amount of missing waste transactions, is your technology set up appropriately for wasting? Are there 2 employees available to waste during procedures being performed? So by identifying kind of like this root cause of the problem early on, you can look at operational changes that you might need to make to account for any variation. So going back to our journey at NYU, in terms of monitoring of controlled substances activities, so previously we were reviewing these 19 reports on a monthly basis. The reports covered various topics: anomalous usage, purchase audits, discrepancy resolution, inventory. The process was super manual, it was very time consuming, and we were looking for technology to kind of improve this. So we reviewed some solutions and found one that included our EMR administration feeds, which is great. It kind of had that missing piece that we were missing. And it kind of helps us include that whole big picture instead of this manual reconciliation. So the application helped us by decreasing time reviewing reports, decreasing the number of reports to review. We now have 100% review. It also helped us improve transparency. And one of the bigger pieces is it introduced unit manager oversight. So previously it was more like pharmacy doing the policing. We were the narcotic police, kind of chasing departments down. And this really, this change kind of helped us put the unit manager in charge of their employees' controlled substance practices, and they were the ones auditing their employees. So it was a game changer. It was kind of a culture shift for us. And it's still a work in progress. So the application also included a way for us to create and house an investigation portfolio for any variants in which we needed to delve a little bit further. So it has date and time stamps for any documentation that we have, and this is super helpful if we ever need to pull this up in times of a DEA audit for any reason. So I want to go back a little and talk about shifting our process from reactive to proactive. So our previous process, as we said, it was very manual. There would sometimes be weeks between detecting a variance and figuring out exactly what happened. And as we all know, asking a clinician about something that happened 2 weeks ago usually doesn't yield great results. Most often they don't remember. They might be out of office on vacation, which adds more time to the investigation. So with this shift to proactive, we're able to hone in on these variances within hours, within days. So we're more likely to have a full picture of what happened and achieve a more timely resolution and kind of decrease that recall bias. So let's talk some more about AI. So there are about 6 vendors out there right now for data analytics and AI software for diversion surveillance on the market now. And there's not like one solution that's perfect for every healthcare system. So if you have the resources to go in this direction, definitely do it and review all the solutions out there. And there may even be something better than all of these 6 in the near future. So definitely do your research and don't limit yourself. So we talked about auditing and how we're able to make that easier, but what about this added AI functionality? So the solution we chose offers investigative dashboards for the nursing and peri-op areas. So upon login, the unit manager sees this risk identification scoring of his or her staff, and it highlights users whose behavior is unusual compared to their peers. So it looks across metrics from all analytics, and then it kind of creates a normalized behavior profile of normal behavior on that unit. And then it compares each user to that normalized profile. So not to get too into the analytics weeds, but basically it's given unit managers, as well as us here in pharmacy, kind of this snapshot oversight of the general practices on a unit and any users that are outside those normal practices. So it also displays if a person's ranking on this risk identification has increased or decreased over the last 30 days. So that kind of helps us delve deeper and investigate anything that looks out of the norm. So I won't go too much into these, but the risk score that we're talking about for this particular program we use, it's derived from a few different reports. So we have variance trends. Just real quickly, it highlights trends in documentation inaccuracies across individuals. Dispense patterns highlights patterns in med handling by individuals in those instances. And this is specifically when meds are dispensed, but no administrations are recorded in your EMR. Med trends highlights trends in med usage and handling across individual team members. So once again, we have this normalized profile, and anyone trending outside of that, it'll flag. So action times highlights individuals whose behavior related to the elapsed time between transactions stands out. So if someone on a unit regularly removes a controlled substance and administers or wastes it 3 hours later, but their peers on the same floor stick to the policy, which is everything done within 1 hour of removal, the person will be flagged and will stand out on this report. User mobility highlights patterns and documentation from specific users across departments. So basically this one looks at if a certain person appears to have activity on multiple floors compared to their peers who may have activity solely on their unit. So, you know, in this case, maybe this person has picked up some overtime and they're floating to different floors. And this kind of brings back why we have that unit manager oversight. We in pharmacy would definitely not know if a nurse is picking up overtime and floating to different units, but their manager would know something like that, and also would know that this is not a real issue to look into because they know the staffing. Waste network, so this highlights users whose waste behavior is unusual compared to their peers. Full package waste, this highlights patterns of instances where the entire contents of a package are wasted. So this is something we don't normally see too often. If someone's pulling out full packages for an anesthesia case and wasting everything at the end of the case, maybe this, maybe it's not so much diversion as maybe this needs to be a practice change on how cases are prepped. Shift analysis. So this is something that we're actively working on rolling out here. It's not fully live here yet, but this incorporates data from your hospital's time and attendance software. So we use Kronos here, and it kind of creates these shifts for providers based on their clock in and clock out times. And so the application will compare this info to event data. And if we see that something was happening outside their clock in or clock out time, might be something to look into. Was their password compromised, or were they here doing something? So you can see this is kind of next level reporting that gets smarter over time, and it's also just one product out there, but it just gives you an idea of the kinds of capabilities that are out there right now. So after our system-wide implementation of our new data analytics software, we knew we needed to look at our investigative process and kind of tighten up what we have there. So we took a couple of our committee meetings to brainstorm and devise a workflow that was compliant with our regulations, of course. It had to be helpful to staff, and it had to be able to be used throughout the system for all disciplines. So I'm showing here our response workflow as a sort of example. And it may be hard to see, but I went a little crazy with Visio and with some colors. But having this workflow drawn out here helps us to ensure that no matter where or when an incident occurs, whether it be in a retail space or our operating room, whether it's at noon or at midnight, we try to approach it in the same fashion as much as possible every single time. So what that allows us to do is minimize the response variation and minimize risk to our organization if we determine that we need to start with this workflow. So the investigation starts at the top in green with the identification of the concern. So it might be prompted by reporting, it could be a concern raised, it could be irregular personnel behavior noticed by a staff member, or any other sign. So then we proceed with the unit manager in conjunction with pharmacy running and analyzing reports. So from there, we kind of divulge into 3 pathways in the yellow boxes. We have an IT systems opportunity, a practice opportunity, and suspected diversion. And we have different questions kind of built in here to kind of help guide whichever pathway we need to go to. So the IT systems opportunity is in the yellow box on the kind of top right. And as you can see, it's pretty short. It doesn't usually involve a documentation or missing med issue. It's kind of the easiest to resolve, and it usually just involves a ADC issue or a mapping issue within our software. Another pathway results in a practice opportunity, which involves documentation errors or practice, like I said, a practice opportunity, but really no missing drug. And this is what we see most often, thankfully. An example is a scenario in which a nurse wasted a drug, but documented the incorrect amount. So over time, you'll see these practice opportunities decrease as each one is kind of like a sort of learning opportunity, an education session, and over time, hopefully staff practices will tighten up. But we also still, on the other hand, want to make sure to track and trend these in case they are actually issues to look into. So the last pathway involves suspicion of diversion, which usually involves calling together our drug diversion response team that we talked about earlier, and going through the investigation process, reviewing reports, reviewing everything from security camera footage, interviewing the employee with security, possible for-cause drug testing if your institution allows that. And from there, if necessary, the process and parties to involve and report the issue to. So we include regulatory, general counsel, human resources, labor relations, and possibly professional boards. And of course, we have worked into here helping the employee. That's one of the major things we want to do here is help them get the resources that they need to safely combat the issue. So since we've involved all of these parties from the beginning as they're part of our steering committee, we have their buy-in. Everyone should know what's happening when we loop them in, and they should know the proper steps to follow. So this workflow will be something that you continually refer to and revise within your steering committee. So I know we reviewed a lot. Let's just go over some key takeaways. You'll want to establish some guiding principles for your program. Your committees should be multidisciplinary and system-wide, and ensure from the very beginning to include your senior leadership as well as your local site leadership for their buy-in and support from the very beginning. You'll establish best practices in mitigation, including technology and analytics, and you'll want to assess this from a closed-loop system perspective. So it's also important to establish, document, and have readily available your investigation process that we just reviewed to minimize risk to your organization so that when an incident occurs, it's addressed in the same manner every time as much as possible. And you'll also want to establish your ongoing education to support all of this good work. You'll continually review everything to make sure the gears still align, and you'll still need to account for new sites, new disciplines or services, new personnel, new technologies that are out there, brand new solutions, current updated regulations and new best practices that might be published. You'll also want to look at new ways to game the system and kind of put yourself in a diverter's shoes and see what part of your process is able to be broken through and kind of apply some strategies to deal with that. Finally, you'll want to track and trend your data, and your control substance committee is a great place to do this and report out to all your stakeholders to keep your organizational buy-in and culture on track here. So this is a lot. Where do you want to start? If you don't have anything in place, a couple of good resources, you can pull up ASHP's guideline on preventing diversion of controlled substances. There's a great appendix in that document, which is kind of like a self-assessment checklist. So you can kind of really gauge where you are already with your controlled substance process. You'll also want to check out the Minnesota Hospital Association. They have a great document called the Roadmap to Controlled Substance Diversion Prevention, and there's a new version 2.0. So like I said, it's a great document, and there's also an associated toolkit to help you self-assess and start getting your program up and running. So I have here my references. And thank you so much for having me. I'm happy to take any questions.
Thank you for that, Dr. Arya. We actually do have several questions, so we will try to get to as many as possible with the time remaining. The first question for you, Dr. Arya, is what strategies have you used to ensure everyone who is involved in your drug diversion response team stay engaged? So how do you, discourage representatives from no-showing?
So I have to say, this was a lot easier when we had in-person meetings and we would have some good food on hand, so everybody would come to grab a sandwich. But I think honestly, once you have that buy-in and once people see really the gravity of, the situation, and we actually go through some cases of what's happened, some actual diversion response team actual instances and kind of do that debrief, people understand their role, they'll get involved, and that kind of prevents the no-shows, is keeping your team engaged, and also just making sure to meet regularly. You may want to start out monthly and then move to quarterly once kind of the activities tapered off a little bit. So that's just something to just really keep everybody engaged. And make sure that all campuses are involved so that we have that system-wide engagement.
Great, thank you, Dr. Arya. Another question that we have from the audience is, how do you handle the checks and balances of purchases? So specifically the people who are approved in the controlled substance contract.
Okay, balances of purchase. So I think what I'm getting from this question, so for every step of the process for purchasing, we kind of include all that paperwork and reconcile it together. So we have a different person who is assessing what we need and kind of emailing our controlled substance manager as far as requests for inventory. We have a different person actually placing that order. When that order comes in as in checked in, that paperwork is also reconciled, and then one last person, a senior manager, works through all these documents along with the ADC transaction of stocking the controlled substances once it's finally checked in and everything. So we kind of have this closed loop paper trail, and one final person is kind of checking off all of those steps. So we try to have a different person doing each of those steps to have that redundancy in place for those checks and balances. I hope that answered that question.
Great, thanks so much. Another question that we have is did you include ambulatory and office care settings in your workflow development and policies, or was that separate?
We did include our ambulatory sites in our workflow, and really any area that we consider Article 28. So as many locations as we can that we have oversight of. So and we try to hold everybody kind of to the same policies and standards as much as possible. So yes, we do include those sites.
Thank you. Another question for you is, in your experience, how often are the activities of diverters reported by their coworkers? And, have your efforts engaged or reminded, you know, workers about their professional obligations to do so, to report any suspicious activities of coworkers?
Yeah, I think this all goes back to really that education and kind of giving them the tools that they need to know what does diversion look like, what does an impaired person look like, I can say we have had really a mix of types of reporting that launches an investigation. It could be anything from someone seeing someone impaired, which has happened, and it can be reporting. It can be anything from seeing a wrapper of a controlled substance, like an empty wrapper in a stairwell, which has not happened here, but I've heard of that in other locations. So, but it really just goes back to culture and really giving everyone that empowerment to know what does diversion look like, and actually reporting it helps the individual, helps the patient, helps the system as a whole, and really just them knowing that it's doing the right thing and what to look out for.
Okay, great. Thank you. And I think we probably have time for one last question. It is, how did you get nursing buy-in to perform their own review?
So I think really what changed it for us was the implementation of the new software that I reviewed. It is really user friendly, and actually before with the manual reporting, we were sending these reports to nursing, and they were kind of like, what do we do with this? It's really like not user friendly. It really just shows the ADC feeds. So they were used to getting reports and they were used to being asked to review them. So when we went live with the new software, it wasn't really adding something to their plate, but it was kind of replacing it with something that was user friendly. It gives them that transparency for their staff. And honestly, the feedback that we've gotten here has been, some of our nurse managers have said, we would love it if this would include every med, not just controlled substances. Which I was like, okay, slow down. I think we'll just stick to controlled substances for now. But they really enjoyed having that transparency because really when you think about it, there's nothing out there that's showing them for their staff really like how they're practicing, what's going on, how are they actually administering the drug that they removed. It's kind of like this new level of oversight and transparency that they had. So it's still a work in progress, but it's nice to see the variances go down because they really are usually practice opportunities, and so it's been a great thing that they've liked having that oversight. So we've been very lucky. I think the key for us was it was kind of replacing a clunky process with something that was more user friendly. So it was helping them do their job.
Great. Thank you so much, Dr. Arya, for this really, informative and really great CE and webinar today.